this is crazy. It's supposed to be healthcare.
And it was just mind-boggling. There's such a great opportunity to lead in this space.
Find a partner that meets your needs.
Put yourself in the patient's shoes.
And when patients understand, patients are happy.
Organizations that succeed in this are going to be the ones that bring in RCM.
We're always looking for chances to do better.
The problem in our industry is
all right, welcome everybody. We're back for another Vendor Voices episode. Today we got Adi Tantravahi from Cofactor AI. How you doing today, Adi?
Good, Ryan. How are you? It's great to be here.
Thank you. Yeah, I'm doing good. So as everybody knows, Vendor Voices episodes start with the Snapshot challenge. We dive right in. Adi, are you ready for the challenge?
Absolutely. Let's do it.
All right, man. Here we go. Question number one. Who is Cofactor?
So Cofactor is a healthcare technology company based out of Chicago, Illinois. We set out with the mission to help healthcare organizations and healthcare providers both realize and capture the full value of care that they're delivering. This means a lot of different things, especially to a lot of different people. But in particular, we started with helping these provider organizations appeal very complex clinical denials.
All right. Question number two. Who does Cofactor serve?
Yeah. So today we primarily serve hospitals and health systems, and we started focusing on the inpatient side, and we're starting to think about how we expand on that.
All right. Question number three. What problem is Cofactor solving?
So at the highest level, the problem we solve is that healthcare is incredibly, incredibly complex. There are nearly something like 10 administrators for every physician out there. There is this very difficult and obscure process that healthcare providers need to go through to get paid. And we are helping sort of simplify and untangle that for them.
Well, you got the right audience. Question number four, how is Cofactor solving that problem?
Yeah. So like I said, today we started with helping these healthcare organizations appeal very complex clinical denials. And so usually what happens today is a healthcare organization will receive a denial, come in through a couple of different formats, but they'll receive that denial. They'll sort of route it to the right team. Usually these need to get routed to a clinical team. So it's former nurses or somebody that's actually working them. And these nurses have to dig through tons and tons of information. They have to dig through sort of longitudinal EHR data to understand why a claim might have gotten denied. They need to dig through labs. They need to look for evidence. And they have to take all of that and actually put it into an appeal to send back to the payer or the insurance company. And right now they spend anywhere from 60 to 90 minutes, sometimes even more, depending on the complexity of the case to work it. And we cut that process down to 15 minutes using artificial intelligence because we're able to sort of intake all of the information related to a denial, and we're able to sift through it to find discrepancies across various sources like the actual denial itself, the medical record, standard of care guidelines, coding guidelines, medical calculators, payers' policies, contracts, so on and so forth, until we can sort of get to the crux of an argument. We sort of synthesize that and turn that into an appeal, and we're able to do it in the span of a couple minutes.
All right. Thank you. And last question, how is Cofactor solving that problem differently?
Yeah, that's a great question because, as you know, there's lots of artificial intelligence in healthcare, especially in revenue cycle, especially over the last couple of years. So the immediate thing is that we're solving a very niche problem in healthcare that most people have not started to address, which is, I think we'll talk about this once we get into it a little bit later, but things like DRG downgrades and medical necessity denials, really these very high dollar value denials that are bogging down these hospitals that they're just not able to get to. We're helping them just power through them and ensure that they're able to recover all of that money. The second way, though, is we are actually incorporating pieces of information that other sources are just not able to actually incorporate into their platform because it's actually very difficult to be able to effectively sift through sometimes thousands and thousands of pages of information to get to the crux of why something got denied.
All right. Just under a minute to spare. How you feeling?
Great.
I didn't give you a chance earlier, so how about you tell our listeners more about yourself, Adi?
Yeah, absolutely. So I'm Adi Tantravahi. I appreciate you saying my name right at the beginning. I am the CEO and co-founder of Cofactor. Like I'd mentioned, we are a healthcare technology organization that's set out to help healthcare providers realize and capture the full value of care that they're delivering.
All right. Well, I know as the founder, right, you're a fellow entrepreneur. I have the utmost respect for that. And I'm always interested in origin stories of people like yourself. And for you specifically, if I understand correctly, this is your first company in the rev cycle space. So I got to ask, are you just crazy, or what brought you into the wonderful world of rev cycle?
Oh, I'm definitely crazy. This is my first business ever. So let's start there. Never started a business before this one, but the sort of origin is I actually was not planning to start a business. It was not sort of in the cards for me, at least in the next couple of years. My plan was to go get a PhD, and that was sort of the track I was on. I'd been working pretty heavily with uh AI/ML like techniques, doing research with things like LLMs and NLP and so on and so forth. I was visiting home for the summer holidays one summer, and I grew up in this family of doctors. So from a very young age, I was always exposed to the medical system. I had no desire to go into medicine. I did not want to become a physician. I didn't really think about medicine as a space for entrepreneurship, but I was visiting home for the holidays. I asked my aunt, who's a physician. She's also a business owner, and she's also a medical director at a regional hospital in South Texas. I asked her if I could shadow her. I spent the whole day with her. I'd followed her around her clinic. I'd followed her around the hospital. To be honest, I'd shadowed her before, so I didn't learn a whole bunch. I didn't see anything new through that process. But at the end of the day, I was sitting in her office waiting for her to finish up with her day so we could go home. And her appeal specialist from the revenue cycle team comes in with a stack of DRG downgrades about like this thick. They sit down for, I don't know, maybe like 2.5, 3 hours to talk about how they were going to respond to them. And I just witnessed the whole conversation. And I just could not believe this is how she had to spend part of her week. The whole thing just seemed really absurd to me. And so I started digging in, and I realized that there's this like massive, not just administrative, but clinical problem that's bogging down all these providers. And it also occurred to me as I was just sort of in the thick of working with this new technology that makes this particular space just ripe for disruption.
I think 2025, at least in the revenue cycle industry, like it's the year of AI is what it feels like to me, where it's finally being adopted in certain areas, right? So you mentioned you were kind of blown away when you shadowed your aunt and the amount of time that they spent just on a stack of DRG downgrades. There's a lot of things that are probably shocking to many who haven't been in our field before. Have you come across anything else so far that's maybe a funny story or just something that was a, oh my goodness moment? I can't believe this is happening.
So I think I hit that every single day. And I'm not exaggerating. The most surprising part about coming into the space was just learning how the sausage was made was really depressing, honestly. It's like this very Kafka-esque process that there were thousands of codes. There are different types of codes. You need to like be able to match them all together. There's a myriad of different payers and policies and contracts that you have to navigate to get things right. And then the incentive structure in the U.S. healthcare system is such that payers and providers are essentially fighting over the same dollar. And so everybody has these perverse incentives where, payers are always talking about fraud on the provider side, which is actually not as pronounced as they want you to think. And then the sort of other side of that is payers are creating this very deliberate, opaque process so they don't have to pay because they get to keep those dollars for themselves. And so they're always coming up with these new tactics to either find ways to deny claims or kick the can down the road so they can pay it later. And it was really, really surprising. I think there were also like other parties that were not specifically payers and providers that really surprised me. Like, this is crazy. It's supposed to be healthcare. You're supposed to be taking care of people, not looking to extract every single dollar from every single angle that you can. We were having to navigate all of this bureaucracy that frankly just should not exist.
Yeah, I well said across the board. I can relate to a lot of that. When I first started in revenue cycle, was seeing these denials and was elbow to elbow with the billers, and they're just like, yeah, well, it's these insurance companies being insurance companies. I'm like, there's no way. Like, there's no way insurance companies are just trying to screw up. Learn real fast how the game is played. But I'm with you too, right? I'm still blown away, I'd say, pretty much every day by something. It's so surprising that nothing's surprising anymore. It's a bit terrifying. But let's talk a little bit more about Cofactor and your journey, somewhat still early journey. So maybe first let's talk about what have been some of the biggest challenges for you and for Cofactor.
Yeah. The challenges are countless. I could not count them on my two hands. The biggest one is just learning about healthcare when you don't come from that background. So we've gotten to know a lot of very, very smart and good people in this space. And one of the questions I like to ask everybody is, like, how did you get into revenue cycle? And the answer, the most common theme is just like, it was a total accident. I got a job out of college. Or like, my dad,
I could have told you. I could
Yeah,
have told you what you were going to say. Yeah, I fell into it.
exactly.
That is 9 out of 10. Yeah.
And the beautiful thing is, or like, the thing is, like, everybody sort of got into this space by accident. Like, nobody grew up saying, I want to work in rev cycle. But you had to learn about all of this complexity. And like, it's very funny. Like, I have all this knowledge in my brain, and there's like a very specific subset of people I can geek out about it with, and like, that's it. But the path to learning all of that it's very nonlinear, and it's very hard. And like, every single day I'm sort of like sometimes questioning my assumptions about what I know. And like, I have to go and like, we have tons of advisors and experts and subject matter experts that I go and like say, hey, this is my understanding. Like, is this right? Because somebody just gave me this new piece of information. So I think like at the most basic level, like that's been the hardest thing. But, we set out to solve a problem for healthcare, but in order to solve it, like, we can't just build a product. We have to take the product to market and get people to actually use it. And the process of getting into a healthcare system, I know that's not the point of today's conversation, is very, very hard though. There are a lot of people involved. Healthcare organizations they're risk averse. They're conservative for like very good reasons, not just because they operate on very thin margins, but they're dealing with very, very sensitive data. And so learning how to get through that, I think, would be, I like to say this to my team, like, selling into hospitals, it feels like you're eating glass sometimes. But if like that's the quote unquote only nutrition you can get, like, you have to eat the glass, and it's tough.
Yeah, it's it's an interesting market, I think, but I'm glad to hear what you were saying earlier. Always retesting the assumptions and asking those questions. It's no one person, let alone one team or one organization, in my opinion, can keep up with all that. So to have those outside advisors is critical to success, not just for a startup or an early stage, but established companies too. And your assumption yesterday, or the facts yesterday, may have been true yesterday and are
Yeah.
not today. So you always got to be retesting. I think that's part of why they're, not just vendor to vendor advisory support, but why provider organizations will always need vendor support. You just simply can't house that knowledge. And maybe AI will make that different. It's doing a lot of positive things today, but it's not quite at that scale yet. Who knows what's to come? But so plenty of challenges. There's got to be some good stories too. So what have been some of the early successes?
There's some great stories. I mean, I remember when we launched into our first hospital, and it's funny. I mean, I was as nervous as I could be. I also found out our customer was also nervous as they could be, because they were, our very first, and we were upfront that they were our very first. The the biggest sort of, I think the most exciting moment for me and the team was when we actually started to see it work. It wasn't just that our users and the hospitals were having a great experience working with us and our solution. We were winning for them. We were actually creating tangible returns on their investment. We were overturning denials that are like sometimes 3, 6, 9, 12, 15, $20,000 that they got to actually keep, and it helps them stay in business. And like that, I think it was really challenging to get to that point. It made it all worth it when we actually realized, like, okay, this works. We are able to do this. And then we were able to build on that, because then we started launching into more hospitals. And we started to see the process of our launches be repeatable. And we knew like, okay, there's a playbook here. There's something, it's not unique to each hospital. We can see this work. We're pulling strategies. Our hospitals are all learning from each other because we're a sort of a centralized space where we can pull things that are working from another hospital really well and apply them elsewhere. And like, that feels awesome. As somebody building something, like when people get value out of it, it makes it all worth it.
That's awesome. And congratulations to you, and kudos to whoever that client was to be willing to be the first. I always say every CEO is a first-time CEO first. That's somebody else said that, not me, right? But every best vendor ever was a first vendor before they got there. So organizations got to be willing to take chances when it's appropriate in a safe space. And I appreciate too that you were very transparent with that. I think that's equally important. This show was brought to you by Real Partners Consulting, a free-to-provider vendor selection support company. We help healthcare providers find the right revenue cycle partners across technology, consulting, and managed services at no cost to you. If you like what you heard from today's guest, or if you're looking for any other partner in the revenue cycle space, let us do the heavy lifting for you. Reach out to me, your host, Ryan Downs, on LinkedIn or at rdowns@realpartnersconsulting.com, and I will personally help you find the right fit. Now let's get back to the episode. So let's get into the nitty gritty a little bit more. I think it's really important on these podcasts. Really, the objective is to entertain, but really to educate. And so Cofactor, we know, focuses largely on DRG downgrades and medical necessity denials. So first, let's do some simple education. For those who aren't really familiar, can you just define what those two things are? And then we'll get a little bit into, what can we do to fight those things off?
Yeah, absolutely. So I'll start with saying we handle pretty much most inpatient clinical denials. So that includes a couple of other types as well. But those were the first two we started with. So I'll start with the DRG downgrade. So what's a DRG? It stands for a diagnosis-related group. This is essentially Medicare's payment classification system. So a DRG downgrade happens when a payer, an insurance company, reviews a hospital's claim, and they ultimately decide to pay for a less severe and therefore less expensive diagnosis than what the hospital originally billed. So each DRG has a different reimbursement rate based on sort of the expected cost and complexity of treating that condition. So like one example would be sepsis with major complications would pay significantly more than the DRG for sepsis without complications. And so when the hospital submits a claim, they're going to assign, off sort of the patient's diagnosis, their procedures, and whatever complications were there. And then the payer will then review that claim, and sometimes they'll come back and say, well, we don't think that the documentation actually supports this higher severity DRG, so we're going to pay for this lower one. And the sort of impact on hospitals, it tends to be really, really big. So like a single sepsis downgrade, for example, might mean somewhere between like $5, $10, $15, $20,000 less in reimbursements for that case. And this turns out to be particularly frustrating for these hospitals, not just because they're losing this money, but they're sort of, the downgrade is happening because of documentation nuances, not because of the actual clinical care. They're providing the same level of care, but clinicians are just not documenting in that sort of quote unquote compliant way. And so the clinical care might have been appropriate, but if the documentation doesn't explicitly spell everything out in sort of the exact to the T way that the payers want to see it, they're going to downgrade and pay less. This is a sort of similar concept with medical necessity where payers will say, well, we don't think that this thing you were treating for, this procedure you did was actually medically necessary, and therefore we're going to deny this claim. And sometimes you see DRG downgrades take the form of medical necessity denials. Like you really have to read through to understand why they're downgrading something. There are other types of inpatient denials you see, like readmission denials. So a patient was discharged from the hospital, and then, at some point they get readmitted to the hospital, and the payer comes back and says, well, this is sort of your fault. You should have treated this appropriately the first time, and so we're not going to pay for the second visit. And then you need to sort of explain why you did everything right the first time. And, for other unrelated orthogonal reasons, the patient had to come back to the hospital, and that's hard.
Yeah, Ryan came in with a heart attack and came back 2 days later because he was in a car crash. Those things aren't related. Well,
right.
They might have been, but Yeah, but at face value, without proper documentation, it's a readmission. And as we mentioned before, the payers aren't going to go out of their way to find out whether or not those things were related. Correct me if I'm wrong. On DRG downgrades, the other thing I've heard a lot that I'd say over the last 18 months now, even that's been a big issue. And what I've heard is it doesn't always actually come through with a denial. So they kind of get snuck in, they kind of get hidden in. So they'll just pay, the payer will pay, but they'll pay at a lower rate than what was actually billed. And depending on how you have your system set up and how you're taking your contractual adjustments, you might miss it. Is that what you're seeing too?
That's exactly right. So there are like a couple of different ways where this could happen where like you said, it just comes in at a lower reimbursement. If you're not taking note of the fact that you got a lower reimbursement than what you expected, like that's one way. There are also what we call like prepay, post-pay denial. So prepay payer will come back before they pay out the claim and say, hey, actually, we don't think it's supposed to be this high, and they'll downgrade it and you appeal it. Post-pay will be a payer originally agrees that, this was sepsis with major complications. And then 3, 6, 9, 12 months later, they've gone back, reviewed a claim. They've said, actually, no, we overpaid you. You need to give us that money back. And this is particularly problematic for these healthcare organizations because they run on such tight margins and their businesses. They spent that money. And so they don't have it to give back. And so if they're not able to successfully appeal and overturn it, then the payer will start discounting their future cash flows, causing them even more bleeding. And it's just not a good outcome for anyone, at least on the provider side.
Yeah, of course. Well, thank you for that. So hopefully now, everybody listening has a better understanding of not just DRG downgrades and medical necessity denials, but even some more in the inpatient denial space. So let's take it next step then, right? So now that we know what these things are, and I'm sure there's people listening who are going through those problems, let's start with DRG downgrades. What are 1 or 2 steps that organizations can take to address DRG downgrades?
This is it tends to be a hard question because every organization is so different. But I'll tell you the common theme that we've seen across like both small rural hospitals and like large systems, like large AMCs, large nonprofits, a lot of them they understand this is a problem. They don't fully understand the magnitude of it because these are really actually hard to track. They don't come in through your normal claim system. They don't come in through your normal 835s, 837s. They're coming in through payer correspondence that like gets sent to a mail room, and then you might only have 30 days to appeal that. But by the time it gets to the appropriate person's desk, it's like day 27. And so a lot of them are just not able to track things well. And so I would say that's the first thing is just like figure out what's going on, where these downgrades are ending up, who's actually responsible for them, and how you're appealing them. I think the second thing is understanding how much time you're dedicating to it based off what the reasons are. And so let me rephrase that. It's more of understanding why things are getting downgraded, not just understanding that they're getting downgraded, but going in and saying, are we legitimately doing something wrong here, and what do we need to do to fix that? Because a lot of time, like I said, it comes to documentation nuance. And so you can fight these downgrades all you want, but really if you don't get to the heart of the problem of helping educate physicians about why documenting in a certain way is important, it's gonna sort of perpetuate itself. And so I would say like those are the first 2 things to think about is like, how can we take stock of the problem? And then once we've taken stock of the problem, like we need to look into what the root cause is so we can get at it.
I mean, I think that's good tips for anytime you're not getting paid, right? So identify and quantify. Unfortunately, oftentimes you're probably going to be surprised by that quantification. And sometimes quantification is harder than it seems, especially with DRG downgrades. It's going to be tough because to your point, it's coming in at all angles. It's not just give me this denial code, right, over a certain period of time. But then it sounds like after that, I like this too. So, the root cause analysis. And then I always like to look inward first. So it's going to be easier. Are there things that we as an organization can control to prevent this from happening in the future? Be it, different, more diligent documentation. Or is this really just one where, hey, we got to bring this to the JOC meeting. We got to bring this to the payer meeting because they are not doing what they're supposed to be doing. Right. So that's helpful. I think it might be the same, but I'm going to ask. So that, those DRG downgrades, what about medical necessity? Anything specific, any tips specific you would give for that?
I would say a lot of organizations have a better grasp of their medical necessity because they tend to come in through electronic remittances. And so a lot of health systems, whether they're sophisticated or not, do have systems set up to sort of intake those remittances and track them and understand like the codes. And, based off a code, if this is a medical necessity denial. And, there are a bunch of different codes that fall under medical necessity. The thing I would advise healthcare organizations to really do at that point is, if you already have all of this data, you need to figure out if you're effectively appealing them. So we know lots of healthcare organizations, like, they have whole clinical teams dedicated to appealing them, but they're not actually tracking how effective they are at appealing them. So I would say, like, start there and figure out how effective you are, and then take stock of what you need to do to make yourself more effective. So if it's like, we need better letters, you should figure out how you're going to produce better appeals. We just spend way too long on an appeal. We're spending an hour, 60, 90, 120 minutes. How can you bring that down? Because that might be preventing you from getting to all your medical necessity denials. And so in that sort of situation, I think it's less of we need to take stock of the problem, and you've likely already taken stock. So it's like, how can we actually maximize what we're doing for this in particular?
Yeah. And that's actually tracking like your overturn rate and your effectiveness of your appeals is something that, even in Epic, which I would say is widely regarded as one of the more advanced EHRs, it's hard to track. I mean, I've tried to help organizations use the data and the reporting in there, but there's a lot of noise in that. So I do think that's a space where vendors, whether it just be an analytical vendor or an appeals vendor, can often do a better job or a more precise job of actually seeing what that overturn rate is, because, I mean, their
Well,
business depends on it.
the other thing that makes tracking your appeals very difficult, payers do this thing sometimes where they'll, like, internally, we call it like a silent overturn, where they won't actually tell you that they didn't recoup money or they overturned it. They'll just do it. And so you have this sort of appeal outstanding AR. And so you need to go back to follow up on this claim. And guess what? That requires manpower. That requires people to actually go and, like, either check a portal or call the payer and stay on the phone with them to say, hey, did you actually recoup this? Like, what was the outcome? Because this is all part of the payer strategy, but that's rough. I mean, you're contractually owed this money, and they're finding every possible way to not give it to you.
Yeah, there's some of those things you just, you throw your hands up in the air, just like, how do you get away with some of this stuff? Anyway, I digress from there. Let's talk AI. Everybody loves talking AI nowadays. It's technically in your name, Cofactor AI. We talked about it a little bit before. Your educational background is in it, so you're the right guy to talk to. This is going to be a tough balance, right? As specific as possible, but in terms that anyone could understand, how are you actually leveraging AI to do what you guys do at Cofactor?
Yeah. So this is a great question, because AI today means something very different from what it meant like 5-6 years ago. Today, when people think AI or artificial intelligence, they think of ChatGPT, they think of OpenAI, they think of large language models, which are these models that are very good at sounding like humans. 5-6 years ago, when we were talking about AI, people were talking about robotic process automation, actually using computers that mimic what humans would actually do as they interact with these computers, or language processing, where you're sort of using models that can understand semantics within sentences to give you insights, but they're not necessarily good at understanding language in the same way a large language model would. The way we leverage AI today, it's funny, is we actually use all of it. We don't just use the language models, which are like a big core part of our solution. And like I'd mentioned at the beginning, we sort of realized from the very start, we're at this major technological wave, and we finally have technology that can do things that you couldn't do 5 years ago, that make this possible, and that can dramatically cut down the cost to make these things possible. But it's not the be all end all solution. Like, they're actually not perfect. They're not the best. They just allow you to do more. And so we still leverage some of that old artificial intelligence technology. We still leverage all of the things that people were considering state of the art 5-6 years ago. And we sort of have what we refer to, instead of a model, a system that is leveraging different models for different tasks because, natural language processing model for like named entity recognition or something is like more effective than just using an LLM to do that one task. And it is like more cost effective and more effective in the actual task itself. Does that answer the question?
Yeah, I think so. I mean, it's using all kinds of AI, and I'm going to ask you a more targeted question though, because I'm curious your take as someone who knows this stuff way better than me. You mentioned RPA,
Mhm.
and this might be a simple question or it might be a convoluted. Is RPA AI?
I would say today, like there's a form of like, we talk about agentic AI a lot, and like there's a form of agentic AI that mimics what RPA does that I would consider AI, but like traditional RPA from like 10 years ago where you're leveraging Selenium or something like that to build out your quote unquote robots or bots. I don't want to discount it, like it is a form of AI, but it's not the AI we have today.
Yeah, it's interesting. And I asked because I had always categorized RPA and bots as more rules based automation, not as dynamic, I guess, is what I would
Yeah.
consider AI.
I do think there is like there's a whole history behind the term artificial intelligence. Goes back to the mid 1900s, but I think it's sort of a disservice to use the term artificial intelligence because uh, it sort of progressed over time, and that is a form of quote unquote artificial intelligence. You are telling a computer, hey, these are the steps you need to do to complete this complicated task. Like that is sort of a form of intelligence. The sort of I think what caused a lot of RPA solutions to fail, particularly in healthcare, is that they're delicate. So if any little thing changes, it can't update itself on the fly. And so then you go back and say, well, is it really intelligent? Can it really do the things that it's supposed to be doing to fix the problems in real time? And the answer is no, it can't. A human really does have to direct it in the right direction. And as sort of time has progressed and we sort of try to build to a point of what we call like artificial general intelligence, we are building computers that can reason a little bit better and like think through things, albeit not as well as humans yet.
So I think, I mentioned before, I think this is kind of the year of AI and in revenue cycle. It is being adopted more and in certain spaces more than others, like ambient listening, of course, is a big one. I think, coding, authorization still seems to be maybe not as well accepted or adopted as I'd like to see at this point. I don't. What are you seeing out there? Do you agree with that? What do you think the challenge of moving this forward in our industry is?
So I think that there have been a lot of artificial intelligence companies that have come out over the last 10 years because in particular, like healthcare revenue cycle is just ripe for this because like we said, it's just so complex and like entirely human powered and just ridiculous the way it actually runs. Yeah. Phenomenal entrepreneurs have been working on this for a really long time. And I think for a long time, it didn't work the way it was expected to work. There were a lot of promises made because theoretically, like it was supposed to happen. It was supposed to work. The RPA was supposed to do the job, but it didn't. And so I think there's frankly, a very healthy level of skepticism around leveraging artificial intelligence in healthcare and revenue cycle. But I do think we're at a point where it clearly is working. It is working for so many organizations. Going back to just like ambient scribes, they're not the perfect solution. There are tons of things wrong with them. I don't think that they are as effective as everyone claims, but they do work. They do help with physician burnout. They are helping capture, more information that goes into the medical note. And that matters. We are so much further ahead than we were like even 2 years ago. And I think healthcare organizations are starting to see this play out where they're seeing we're not just saving time. We're actually being more effective. We're coding better. We're appealing better. We're taking notes better. Our CDI is getting better. There are tons of solutions in this space that have consistently shown there's ROI today. And it's just, I think, only going to get better and better. And I think if healthcare organizations don't start thinking about that and like getting over their what I would consider healthy levels of skepticism, they're gonna fall behind.
Yeah, That makes sense. I think we've just put AI on this pedestal, right? And
Yeah.
at the end of the day, at least in this point in time, we should be approaching it as a technology that enables us to do our jobs better or to do more quickly. But instead, the gut reaction, I think, for many is AI is replacing. No, like what other?
Yeah.
And in some cases, your bots, your RPA, your stuff that is replacing some of the tasks you have to do. But at the end of the day, there's always exceptions and there's always things you got to be watching out for. And I think AI is no exception to that, right? It's really powerful technology, but it's just
So
technology.
Particularly in healthcare, I have a lot of thoughts on this, but particularly in healthcare, I think the way people should be thinking about artificial intelligence and the way we think about it is Cofactor is building a vehicle, building a car, a truck, whatever you want to call it, and somebody still needs to drive that vehicle. Somebody still needs to ensure that it's put into practice, that it's on the road, that it's being used safely, so on and so forth, that somebody's stopping at the stoplights. I think there are several structural things in healthcare that make artificial intelligence really necessary. And like, I understand the fear of like people feeling like they're being replaced, but the truth is, it's not just that we're sort of the why now, why this technology is important because it exists, but there are structural issues like staffing shortages, policy changes, and just like complexity that's continuously growing that make it necessary. Because if we continue sort of on the same path of that growing complexity, of the changing policies, of the staffing shortages, without having technology to help us adapt to that, our healthcare system is just going to continue to get worse and worse and worse for patients. And actually, I think that's the crux of the issue. We need to think about how this affects patients.
Yeah. Show me an organization, show me a health system, hospital, or provider group that is getting through everything they want to get through. There isn't one, right? Show me a health system or hospital or who feels constantly fully staffed. There isn't one.
Yeah.
And sometimes it's because they can't afford it, but oftentimes it's literally just because they can't get the people in the doors or they can't retain the people. And so, yes, like I'm with you on all accounts. So we're filming this right around Christmas time, and you've been doing this awesome series. By the time I post this, you're going to have to go back in time and find them or reach out to me or Adi. We'll send them to you. But Adi in the Cofactor team made this cool thing called, was it 12 Days of Denials, right? Did I get that right? And so each day, Adi's doing like a 2-minute video on a specific denial and what to look out for in your organization if you're coming across that. Go check that series out. It's super cool. It's super informative. It'd take you all of 25 minutes to get through every single one. And I guarantee if you work in revenue cycle, at least one of them is going to be pertinent to what your organization is facing right now. Adi, thank you for your time. This has been fun. I hope you had a good time. I think our listeners learned a lot. We like to ask every guest at the end, final takeaways, anything you might want to share for our listeners out there. Anything's fair game. What comes to mind?
One of our principles is to figure out how we can be a value add to healthcare organizations, regardless of whether they work with us. And so one of the things I would encourage people to do is go check out our content, go check out some of the guides we put out because they really are information dense. We have one guide that has like specific payer policies and payer strategies to help overturn things. We have one guide just entirely about sepsis and figuring out how you can untangle your sepsis denials because, by the way, I didn't mention this, something like 70 to 80% of all DRG downgrades are sepsis downgrades. And so I would encourage people to go check that out, whether or not you're interested in working with Cofactor or evaluating a new vendor. I think there's a lot of value you'd get by just looking at it.
Well, I personally appreciate that because that's what this podcast is all about too, right? I'm having fun with it and I'm trying to get the word out about different organizations. But at the end of the day, I want listeners to learn from it and take it back to their work and be able to do a better job for the greater good of a revenue cycle and healthcare as a whole. So love that being your parting note. But thank you again, Adi. Appreciate your time. Best of luck and continued success with Cofactor. And until next time.
Likewise, Ryan, thank you so much for having me on. It was such a pleasure to chat with you.
That's a wrap on yet another episode of Vendor Voices. Huge thanks to our guests for their insights and to you for listening. If this episode gave you something to think about, share it with your team. If you'd like to suggest a specific topic or guest, feel free to reach out to me on LinkedIn or at rdowns@realpartnersconsulting.com. Please rate and review, and be sure to subscribe to never miss an episode. I'm Ryan Downs. Thanks for tuning in.